Welcome to the Ask EASL podcast, where leading experts take us through important topics in liver disease from a patient perspective. On this podcast today, we're in conversation with Dr. Massimo Iavaroni on the topic of liver cancer. Can I ask you please to introduce yourself for the audience?
Yes, of course. I'm Massimo Iavaroni. I'm working as an hepatologist in Milan, Italy, and generally on liver cancer and cirrhosis from screening, diagnosis, and management of treatments for patients with liver cancer.
Thank you very much. So talking of liver cancer, Doctor, can you explain, Massimo, maybe the different types of liver cancer that there are, and maybe explain a little bit about each of them?
Yes, of course. Most cases of liver cancer are hepatocellular carcinoma, which means the cancer developing from the hepatocellular cells, and this means that there is a second kind of primary cancer, which is called cholangiocarcinoma, which is less frequently observed in patients, even if in last 10 or 20 years there is an increase of number of diagnoses of cholangiocarcinoma too. And generally these tumors develop in patients with chronic liver disease, as we may pass afterwards. And this means that generally we have risk factors to be checked and to identify patients at risk of developed these cancers.
Perfect. Thank you very much. Why does liver cancer develop, and to what extent does the development of cancer depend on a patient's everyday lifestyle habits?
Okay, thank you for this question. It's very important because if we are able to identify the risk factors, we may reduce the risk of hepatocellular carcinoma to develop in our patients. Almost all patients who develop primary liver cancer are patients with liver cirrhosis or at least chronic liver disease. We can prevent the risk of ACC, hepatocellular carcinoma, we can say ACC, to develop in our patients, reducing the risk of developing liver cirrhosis. In that way, we can consider the main risk factors to develop a cirrhosis. The first of all, at least in Europe, is hepatitis C, hepatitis B, and alcohol. As you can understand, the third of these three risk factors is the most easily to be prevented, reducing the use of alcohol. And this is very important because this is a point for education in our patients and even before to the general population to reduce the risk of chronic disease by reducing the use of alcohol. As far as for hepatitis B, we have the vaccination, which was one of the first example of vaccine to reduce the risk of cancer. And even in those patients who has get infected by hepatitis B, we have a therapy with antiviral drugs that can in some way reduce, not to zero, but at least reduce the risk of cirrhosis and obviously of cancer development. As far as for hepatitis C, this is a very key point because in the last 5 years, the new drugs that has been developed permitted to significantly reduce the risk of HCC to develop and cirrhosis to get worsened by eliminating the virus in the blood of our patients. And this was a very important turning point. As far as for US and at least even in Europe, a fourth risk of ACC to develop is NAFLD and NASH, which means a liver disease due to metabolic syndrome, which can develop in patients with arterial hypertension, diabetes, and obesity. This is very important because, as for alcohol, even for NAFLD and NASH and for the metabolic syndrome, we can reduce the risk of ACC to develop by reducing the overweight of our population, and we can educate even in this point people to reduce this risk by a better quality of their food, and reducing the quantity and reducing the calories of their intake, together with a healthy and behavior with sports.
So, Massimo, aside from the other reasons you've just explained that cancer develops, are there any other risk factors for liver cancer?
Yes, sure. It's very important to know that there are other risk factors for liver cancer to develop, which are more rare disease like autoimmune hepatitis, primary biliary cholangitis, or eventually some genetic disease like hemochromatosis and Wilson disease. And as we can say, all the reason that can put the risk to develop cirrhosis should be considered risk factors for ACC to develop, since the cirrhosis is the background for liver cancer to develop.
So, the next topic I think the audience will be interested in, Doctor, is screening. So, do you screen for liver cancers? And if so, how is the screening done? How often is it done? And why is it really important for patients to attend their screening appointments?
Thank you for this question, because it's quite different from the meaning of screening for other cancers, as for breast cancer or for the colon cancer, because since we know that almost 98% of our hepatocellular carcinoma are going to develop in patients with cirrhosis, or at least with chronic liver disease, we have a selected population to be screened and to be surveyed for ACC to develop. So we should point out that the screening and, well, it's better to call surveillance for these patients, is quite expensive and less easily to be done compared to other screening features in other tumors. But the population is smaller and well selected, because we do not have a real simple test on blood test to be done, but we need to have abdominal ultrasound twice a year in all our patients. So this means that our patients have to get an appointment to a doctor and to have their abdomen studied by ultrasound. This generally take half an hour to be done. And this is very important because this kind of methodology is linked to the uh, experience of the doctor who does the screening. This is very important because it's not so easy screening to be done. However, as we said, you have a selected population to be screening on with it. This is very easy for chronic hepatitis B. This is very easy for cirrhosis of any cause, like hepatitis C, hepatitis B, alcoholic, or metabolic syndrome. It's quite difficult to get this screening for patients with the NAFLD not developing cirrhosis, for those patients who has no cirrhosis but has the risk of liver cancer to develop due to diabetes and overweight or obesity, because it's a huge number of patients, and sometimes ultrasound has a limited in terms of sensitivity on these patients. But however, why we should do screening and surveillance in our population? Because as far as we know, this is the best way to identify tumor, 1 to 3 or 4 lesions at least with smaller than 3 centimeters, and this means that they can get the best opportunity in terms of treatment, and this is the way to have the best survival for our patients.
Thank you. That's excellent. Thank you very much. So, Massimo, if you do find signs of liver cancer when you perform your ultrasound screening, is that cancer treatable? What are the different treatment options? And is maybe liver transplant considered a successful option as well?
Okay, yes, the reason why we do this screening by ultrasound is because we have a treatment for patients, and we do have some treatments that as early as the patient get, the better is the survival for them. And we have surgery. We can have a resection of the liver if the tumor is small. Otherwise, we can have radiofrequency ablation, local regional treatment like ablation of the tumor by percutaneous approach, or eventually by laparoscopy. And this is the 3 options we have for patients with small liver cancer. If we have the size of the tumor get greater, we have limited option, eventually surgery, or probably a new treatment which has not been perfectly shown to be efficacious as the other option, is radioembolization. For those patients who has more than 3 or 4 nodules and eventually bigger than 3 centimeters, we can have a sort of palliation by means of local regional treatment by chemoembolization, which means to put some chemotherapy in the nodule by arteriography, by vascular treatment. And eventually, for those patients with a more advanced disease, now we have a different choice in terms of systemic treatment. It's something like chemotherapy, but it's quite different, because the classical chemotherapy was not able to cure our patients due to toxicity, because for each of these treatments, we should never forget that our patients has cirrhosis, underlying liver cancer. So this means that we have 2 diseases, the liver cancer to be treated and the underlying cirrhosis that can limit our actions in terms of efficacy, since if we have a small liver tumor developing in a patient with a decompensated cirrhosis, the risk of dying of cirrhosis is higher compared to the risk of dying for the small tumor. This means that we have to choose wisely the best option for our patients. And for this reason, the role of liver transplantation is crucial, since this is the only treatment that can cure both liver cancer and liver cirrhosis.
Thank you, Massimo. That's really clear. Thank you very much. So people talk about the stage of a cancer, but what does staging a cancer actually mean, and specifically with respect to liver cancer?
This is another point which shows that primary liver cancer is different from the other tumors. The way we have to stage our patients is linked to 2 points. The first point is liver cirrhosis. So we should consider a staging system that take into consideration the disease meant as cirrhosis. The same staging system should consider the tumor burden. That means the size, the number of the tumor, and eventually the vascular invasion on the metastasis outside the liver. And third, the staging system should also consider the general condition of the patients. That generally is very important. The mean age for our patients to develop liver cancer is around 65, and now in Italy, in France, and even in Japan, the age is getting older and older. This means that the general condition of the patient is very important to be evaluated too. For these reasons, the best way to stage the disease, for me, for the EASL guidelines and for the American guidelines, is the BCLC system, which is a system developed in Barcelona more than 20 years ago, which take into consideration the size and the number of the tumor, first point, the underlying liver cirrhosis, and third, the performance status, which take into account the general condition, the symptoms of our patients. This means that by staging our patient with this system, the BCLC system, we are able to consider all the characteristics of our patients by cirrhosis degree, the degree of liver cancer, and the general condition. And for each stage we have identified, we have the best option to propose in terms of treatment and, of course, of survival. For example, if I have a small tumor of 3 centimeters developing in a patient with a well compensated cirrhosis and in a good general condition, this patient can get, for example, surgery. If the same tumor develop in a patient with a decompensated cirrhosis, probably liver transplantation should be the first option to be offered to this patient. And finally, if we have a patient with a 3 centimeters or 2 centimeters tumor, a decompensated disease in a patient with symptomatic, with pain in the abdomen, and eventually with pruritus, itches, or other disease, other comorbidities, probably this patient need the best supportive care to get the best quality of life without any active treatment.
So, Massimo, just to be clear, can you have a liver transplant if you have liver cancer? And if so, under what specific circumstances?
Yes, and I'm very happy to explain this point because I'm from Milan, and in Milan, there was a study, very important study by Vincenzo Mazzaferro in late 90s that shown that liver transplant can be performed in patients with liver cancer, in patient with a single lesion lesser than 5 centimeters, or those patients with 3 lesions, the biggest less than 3 centimeters. These are the best candidate for liver transplant. Almost 80% in 5 years will be alive. This was a dramatic point in the management of our patients because we can have the perfect selection of patients. And why we should have a perfect selection for this treatment? Because this kind of treatment is completely different from any other treatment option, because there is a limited number of liver transplant we can get each year, and so we have to select the patient that can benefit most of this kind of treatment. And we should also consider that the main reason to be transplanted is liver decompensation, because those patients with liver decompensation are those patients at the risk of dying in few months if they do not get liver transplant. This means that we should compare the benefit we can get in a patient still compensated but with liver cancer compared to those patients with a decompensated liver disease without liver cancer. So it's a competitive risk, and we should perfectly choose those patients who can really benefit of it. What does decompensation mean? Those patients with liver cirrhosis and without liver cancer can get other complication of their chronic liver disease as ascites, that means the presence of liquid in their abdomen. Otherwise, they can have very high level of bilirubin, 10 or 20 times the normal level, or eventually they can get kidney disease, which is due to the liver disease, which is called hepatorenal syndrome. Eventually, they can have the rupture of some veins that can develop in their esophagus and in their stomach, which are called varices, and if the rupture of them are at risk, the patient who has the rupture of the varices are at risk of dying. And these are all complications of cirrhosis called portal hypertension complication, which are in parallel with liver cancer development, are the two main complications, category of complication of liver cirrhosis. This means that we have two patients, the first with a lesion of 5 centimeters in a well-compensated disease, and the second one is a patient without liver cancer, but with a decompensated cirrhosis, for example, with ascites and with varices and with the need of a lot of drugs to control the disease. Who is the best candidate for liver transplantation? Probably both, but the first one, the patient with liver cancer, can be treated in the wait for liver transplantation with, as we call, with bridge treatment, like, as I said before, chemoembolization, eventually by radiofrequency ablation. And so he can wait to be transplanted. And the second one should be transplanted as soon as possible, because he's at risk of dying in the next 3 or 6 months. We have a way to measure the risk by means of the so-called MELD score, which is a score that we doctors use to understand the risk of dying in the next 3 or 6 months by means of measure bilirubin, prothrombin time, and creatinine, in order to understand who is the first patient who need to be transplanted. And the reason why we consider for transplantation patients who can be perfectly cured of their nodule by means of surgery, by means of chemoembolization, or eventually radiofrequency ablation, are at high risk of recurrence of liver cancer for two reasons. The first one is that cancer cell can still there, and then they can develop a recurrence of the tumor, and generally this recurrence is very early to occur in the 12 or 24 months after the treatment, or eventually we have cirrhosis again. This is per se a risk of liver cancer recurrence in our patients. This is why transplantation is potentially a benefit for these patients. If we think of a longer time, not the 6 months for patient with the compensation, but if we think of 5 years of life.
Thank you, Massimo. And our last question for today is about clinical trials. So, are there any clinical trials specifically looking at liver cancer? And if so, how do patients go about finding out about them?
Okay, in the last years, in the last 10, 13 years, there have been a lot of clinical trials with new drugs to treat patients with advanced liver cancer. The first drug was available for our patient in 2007, and it was sorafenib. Then there were a lot of negative trials with new drugs to treat patients with advanced liver cancer. Then in the last years, we developed new drugs by clinical trials. And finally, today, we have a lot of trials with combination of different drugs to treat patients in first line with advanced liver disease. This means patients with the tumor in the liver, but also outside the liver, who need systemic treatment to be treated, who can not only get local regional treatment to have a benefit in terms of survival. And these clinical trials are generally sponsored by the company who develop drugs. And generally in big areas, we have big hospital, university hospital or big hospital that have the trial available for our patients. Generally, you can get information by the website of the hospitals. Sometimes you have information on the website of the Patients Association about clinical trials ongoing in the region. Or eventually, we have also some clinical trial that has been proposed by doctors, and it is not sponsored by companies. And generally, for this kind of trials, you can get information also in the website of the scientific association, eventually the regional or national association, or eventually international association. We can also have another way to get information, but it's quite difficult for patients. But there is a website of the clinical trial point.gov. You can get information writing liver cancer, primary liver cancer, or hepatocellular carcinoma. Mainly, these trials are focused on patients with more advanced liver tumor. However, in the last few years, we have also trials in early stages of the disease, because a way to reduce the risk of liver cancer to recur in our patients it is to develop drugs that can reduce this risk from the first treatment to the second one, to prolong, if not to put zero, the risk of liver cancer to recur in our patients after a successful first line treatment.
And so, with that, Dr. Iavaroni, I just, on behalf of EASL, would like to thank you for the insights and expertise that you've shared with us today. Thank you very much.
It was a pleasure to me to answer to all these questions. It was really very important for me and for the community.